All right, we are going to start with chapter 1 and learning about evidence-based practice, and this chapter is about evidence-based practice models. So the objectives for this particular chapter are pretty simple. One is to just kind of define what exactly evidence-based practice is and how it relates to athletic training. We're going to look briefly at the 5 steps of evidence-based practice and give you a little bit of a better understanding of what we might call the levels of clinical research, or a hierarchy might be another way to think about it. Usually it's depicted as some sort of a pyramid, so we're going to talk about that as well. So first off, what exactly is evidence-based practice? We usually abbreviate it as EBP. A lot of times you will also see it abbreviated as EBM, or evidence-based medicine. But for our purposes, we're probably just all going to call it EBP. And basically what it is, in a nutshell, is taking the best clinical research that you can find out there on a particular topic or a particular technique or a particular type of treatment that you want to use, combining it with your clinical expertise and what's important to your patient in terms of your patient's values into the decisions that you make regarding how you're going to treat a particular patient's condition. So we're going to talk about each of those 3 things: clinical research, clinical expertise, and patient values, real briefly. So first thing is clinical research. Your textbook kind of goes back and forth between clinical research and clinical evidence, same thing. I prefer the term clinical research just because that way when you talk about evidence-based practice, you're not using the word evidence in the definition. So clinical research, what does that look like, or how do you go about finding good clinical research articles that are already out there? So there's a couple different ways to kind of think about it. It's either developing your own line of clinical research, or looking at a specific research question that you have, or trying to kind of dig into different databases and things like that to see what research is already out there. So it's a systematic process if you're going to do research, where if you think way back into probably 5th or 6th grade science, you probably learned about just science research in general and the idea of having some sort of hypothesis, and you use that question to generate some sort of research, and then you conduct a study using particular methodologies, you get evidence, you analyze the evidence, and then you draw your conclusions. That's pretty much what we're talking about here, is the exact same thing. So clinical research tends to try to answer a specific question, and we'll talk about that in the next chapter in terms of how you do that. You do that with something called the PICO format, which kind of helps you develop a good question to answer. And then good clinical research typically incorporates some sort of randomization, which basically just means that things are done in such a way that bias is minimized. Bias on the part of the person doing the research, so the researcher or the investigator, or what you might, if there's more than one person doing a study, the primary investigator, the secondary investigator, co-investigators, whatever, that those individuals are minimizing their bias when they do the study. And so you can have randomization of subjects and treatments, so that not only do the subjects not necessarily know if they're getting, the same treatments or not, but the researchers don't know either. And so what that does is it basically makes the research more relevant, makes it more meaningful, and measures the impact in a way that you can look at the conclusions that were drawn and say, yes, this was a good study. It was done well. I can take the conclusions and actually apply them to practice. Clinical expertise is then, just like it sounds like, your own personal experiences that you will eventually gain through caring for patients and treating them in specific ways. Clinical expertise develops over time. It's not something that happens overnight. It's something that takes years and years and hours, and you're going to make mistakes, and that's okay. That's how you learn. And in my opinion, I think it's, sometimes that's how you learn best, is when you make a mistake and you figure out what you did well, what you did wrong, what you could have done differently. And ultimately, after you've been practicing for a while, you do kind of get a sense of pride about what you're doing and what you're able to provide to your patients. And expertise tends to end up being one of the driving forces in how you practice clinically. What you do with your patients based on your own values, your preferences, what you think works, what you think doesn't, techniques, all kinds of different things all go into clinical expertise. But I think the biggest thing is to remember that it develops over time. And I think all of us, myself personally, I don't know that I will ever feel comfortable calling myself a clinical expert in anything. But I think you get more comfortable with doing certain things, and kind of where your strengths and weaknesses are as you become more seasoned in the profession. And then the last kind of cornerstone of EBP has to do with the patient. And even though it's the last one we talk about, it's probably the most important. So you're going to treat your patient based on what you know and based on what research tells you, but perhaps most importantly on what the patient's values are, meaning you have to take those into account when you are having conversations with patients about what you're going to do, why you're going to do it. You have to make sure that they're okay with it, that it goes, that it doesn't go against any beliefs that they might have culturally, and we'll talk about that later on. That you address any preconceived notions they might have about, well, I've heard that, dry needling is the best thing going out there, and so I want you to dry needle me. Well, that may be great, but it may not be something that makes sense for where they are, in their treatment process. But just really understanding that you have your own experiences, but they have theirs. And so sometimes their preconceived ideas or beliefs come from some of those previous experiences. It could be that they will be completely fine with whatever you do, and there never has to be a long-winded conversation about it, but it could be that they've experienced distrust with medical professionals in the past that kind of color what they think. And so you never know, but you've got to be willing to try to find out and have a conversation about it, and also understand that some of those intangible things, like how your facility looks or how you look professionally, are you dressed appropriately, are you presenting yourself in a professional manner, can also go a long way towards kind of what the patient sees and what they end up thinking about and valuing in the process. So the next thing to talk about are the 5 steps of EBP, and I'm not going to go over these in a whole lot of detail because really that's what the next few chapters of the book are about. So just briefly, the 5 steps of thinking about EBP are creating a good, clinically relevant, and what we call searchable research question, conducting a search of the evidence that's already available to see what's out there to help you address that particular question or concern. Once you've gathered that evidence, you want to what we call critically appraise it, or determine whether or not you feel like it's good evidence, that you can use it to help inform your practice. After you've done that, you're going to choose and implement a particular treatment, incorporating those things that we mentioned, the evidence that you've looked at, your values and your patient's values. You're going to implement whatever that treatment is, and then the last step is just figuring out, did it work? Looking at what the outcomes are and determining whether or not, this is something I would do again, or no, maybe this isn't working as well as I would like, so let's kind of come up with something else and try that and go from there. And then the last objective to talk about in this chapter is just looking at different levels of evidence. So this is the image that's in your book, and we talk about levels of evidence, and they usually, if you go out there and Google levels of evidence, you're going to get pictures of pyramids that look very similar to this in terms of what the different levels are. So we're going to briefly kind of talk about a few of these. When you look at the pyramid itself, one thing to remember is that as you move from the bottom or the larger portion of the pyramid to the top or the smaller portion of the pyramid, the quality of research increases, meaning that there is more evidence to support what's in those particular types of articles, but the quantity typically decreases. So there aren't going to be as many articles in a particular category or level of the pyramid the higher you go, but the quality of the articles that you will find based on the type will go up. So each level kind of has a distinct purpose. I'm not going to talk about all of them because, again, we'll get there in other chapters, but they all have a particular function. And again, like I just mentioned, lower levels might be considered weaker while higher levels might be considered stronger in terms of their relevance or the amount of evidence that they have in them. Briefly want to talk about the 4 highest types in the pyramid. The first one of the 4 is what we call randomized controlled trials. So these are studies that are similar to what I was talking about earlier, where they have randomization in them. These are probably the ones that you're going to look at or find or read the most. So, you have participants that are randomly assigned to different groups, and they talk about how they performed the study, why they did it, what they found, and then whether or not it worked or didn't work. The next level up are what we typically call CATs, or critically appraised topics, and these are kind of like they sound. They are one particular topic that clinicians will look at to try to determine whether or not any other studies have been done out there on that topic already. So it's almost like are there any RCTs that exist in this particular topic? Systematic reviews and meta-analyses. So the actual pyramid in your book doesn't include meta-analysis or meta-analyses. I'm not really sure why, but systematic reviews and meta-analyses are, in my opinion, somewhat similar. They're a little more all-inclusive. So the nice thing about them is that if you can find one, if there's been one that's been done on a particular topic, it's kind of a one-stop shop. They take maybe 5 or 6 other articles that were probably randomized controlled trials. They look at them, they put them all together, and then a systematic review will talk about what the results of all of that literature was on that one particular topic. So it's kind of nice from a reference standpoint, because it usually includes information from a lot of different studies. Meta-analyses are somewhat similar to that, only they will talk more about what the methodology was that was in the article. And then one other thing to note is that systematic reviews and meta-analyses, when we talk about the NATA position statements in this class and in other classes, systematic reviews and meta-analyses are typically the documents that were looked at in order to create the information that's in the position statements. So just something to keep in mind for later. The other things that you'll see on the kind of the sides of the pyramid are filtered and unfiltered articles, which basically refers to whether or not the publications in that particular level of the pyramid went through a peer review process, which we will talk about later. And then the TRIP database, or TRIP database, however you want to say it, is a particular type of database that will search for what we call peer-reviewed and unpeer-reviewed, or unfiltered or filtered articles together. And we'll talk more about databases later on as well. So the bottom line in talking about EBP is that it incorporates three different things: the best evidence from the research that you can find or from research that you do yourself, your own personal experiences and clinical expertise, and the patient's perspectives, values, beliefs, input, all of those three things coming together to help you inform the types of treatments that you do with your patients. And the bottom line, the thing to keep in mind is that evidence-based practice should always be patient-focused.